Welcome back to The Deep Dive. This session is adapted from an article written by a clinician, published on Mentalyc, and we're bringing it to life here in audio for therapists who, prefer to catch up on these kinds of insights while they're on the move.
Yeah, and we're diving into a challenge that I think is pretty universal in practice, which is working with reserved clients.
Absolutely.
This piece comes from Gargi Singh, a psychologist, and she offers a really thoughtful approach to that delicate process of building rapport when the client doesn't, easily fill the space.
And since this deep dive draws on a source from Mentalyc, it's probably helpful to know that it is a clinical intelligence platform. It's designed really to support therapists with the demanding side of documentation.
Right.
But as we're going to see today, that function can often overlap directly with clinical reflection.
Oh, it does, because the challenge we're talking about today really centers on the information we miss. I mean, we've all been there.
Yeah.
You're working with a quiet or maybe a guarded client, and you just sense this subtle, almost instantaneous shift.
Like a flicker of something.
Exactly. A flash of tension, a brief, sharp avoidance of eye contact, or even just a tiny change in their tone. It's the evidence of a micro-rupture in the alliance.
But it's so fleeting.
It's so fleeting that you're so engaged in the moment, holding space, that you miss the cue entirely.
It's gone before you can even mentally process it, let alone label it or think about intervening. And in that moment, our cognitive load is just maxed out.
It is.
We're tracking what they're saying, managing our own reactions, planning the next question, trying to maintain presence. It's almost impossible to be an objective observer at the same time.
That's the crux of it. These nonverbal cues are absolutely critical to understanding the client's internal state, their trust, their comfort level, their perception of you.
Yeah.
But they're the first things to slip by when a client is already guarded.
Yeah.
Because they're not giving you much verbal data to, cross-reference.
So we end up spending all this energy on the words that could be said, and we miss the signals being sent through the silence itself.
The absence of words, exactly.
Okay, so let's unpack this a bit. I think a good place to start is differentiating the three categories the source material highlights, because we often group them all under quiet,
Right.
but the strategies only really work if we address what's underneath. The article separates them into shy, quiet, and reluctant clients, and that distinction feels crucial.
It absolutely is. So let's look at the shy client first.
Yeah.
For this client, the primary barrier isn't usually the therapy itself. It's more about social anxiety,
A fear of judgment.
a profound fear of judgment. Yeah, they can feel really exposed in a new, intimate setting. So for them, the silence isn't avoidance in the same way. It's a defense mechanism driven by anxiety. They just need time,
Patience.
patience, and the complete normalization of their need to go slow.
Okay, so then you contrast that with what the article calls the quiet client.
Right. And these individuals might be totally comfortable socially, but they are specifically uncomfortable or just unsure in the therapy room.
So it's context specific.
Exactly. They might lack confidence, not know the, quote, rules of therapy, or they might genuinely feel their problems aren't, big enough to talk about. Their silence is more from a lack of confidence or clarity, not social fear.
And then there's the third group, which can be the toughest, the reluctant clients.
Yeah, these are often the clients who have been coerced or pushed into therapy.
A mandate from a spouse, a court order.
A family intervention, exactly. So their barrier is skepticism and a feeling that their autonomy has been, violated. They need a ton of collaboration and a real demonstrable transfer of control to even start to engage.
Their silence is a form of control.
It's often a deliberate act of resistance, yeah.
So if our usual tools, active listening, paraphrasing, if they all rely on the client giving us verbal material, how does the source say we build rapport when, the well is dry?
We have to shift focus. It has to become about nonverbal engagement. The article really reinforces that subtle practitioner behavior becomes the main lever.
Okay, so for shy clients, what does that look like?
It means minimizing the intensity of direct confrontation. So we have to actively normalize the silence, make it clear that it's productive, not awkward.
And maybe avoiding forced direct eye contact.
Yes, absolutely. Giving them the option to look away, or even, as the article mentions, using side-by-side seating to reduce that feeling of being interrogated.
That's just good trauma-informed practice, really, applied to anxiety.
Precisely. We're just lowering the pressure. But for the quiet client, it's a bit different. We use our own nonverbals to invite them to share.
So an open posture, nodding.
Gentle, deliberate nodding, and maybe subtly mirroring their non-stressful body language. It just shows curiosity and acceptance. It signals, I'm receptive to whatever you share, even if it feels small.
And we can't forget the room itself, the physical space.
No, the article cites research confirming that a quiet, organized room, warm lighting, cozy seating, it all significantly reduces that ambient anxiety. It's an environmental support that makes shutting down less likely.
So this brings up the whole issue of missed opportunities. If these tiny, fleeting nonverbal cues are the key, how do we process them if we miss them in real time?
I mean, we all know that relying on our memory after a tough session, especially one where we felt challenged by silence, it's not reliable.
And this is where it gets really interesting. And for me, this is the main clinical insight here. The most critical part of growth in these cases isn't just what we do in the session.
Right.
It's the therapist's detailed post-session reflection on these micro cues. The slight clench of a jaw, the split-second widening of the eyes. These are powerful clues we need to reflect on with objectivity.
And that's exactly where clinical objectivity becomes almost impossible to maintain on our own. In the room, we're human. We might feel frustrated or have our own countertransference activated, and that emotional experience just clouds our memory of the actual data points.
So we need some way to surface those moments where the dynamic shifted, even if we were too cognitively busy to notice it at the time.
That's where the source introduces this idea of using objective support. It highlights Mentalyc's Alliance Genie feature organically as part of this reflection process.
Okay.
What's so fascinating is that the tool isn't analyzing the content of what's said. It's tracking the structural parts of the interaction that reflect the dynamic.
Things like what?
Things like shifts in how long the silences last, fluctuations in the client's vocal volume, or even changes in how quickly they respond to a question. It's quantifying the nonverbal and paraverbal data.
Which makes a huge difference. If a tool flags that my client's pause frequency tripled right after I brought up, say, topic Y, that data point is an objective anchor for me.
Exactly.
It's like getting a supervision-like insight. It helps me spot the relational shifts, the micro-ruptures that I just inevitably miss in the moment. It helps maintain that clinical objectivity.
It does. The value is surfacing those auto-captured areas for growth in the alliance, so the clinician isn't relying purely on a potentially biased or incomplete memory.
Quick pause. If monitoring these subtle shifting alliance patterns feels familiar, especially with clients where the nonverbal cues carry all the weight, Mentalyc can help. Its Alliance Genie feature supports your clinical documentation and relational judgment while staying fully IPA and SOC2 compliant. You can explore it at Mentalyc.com.
So moving into what we can actually do, we have to focus on strategies that empower the client. Building autonomy is probably the most effective antidote to the anxiety and resistance we see.
That's a great framework. But how do we translate autonomy into a repeatable strategy in the session, especially for someone who hardly speaks?
Well, one of the most effective ways is making consent and autonomy a routine practice, but in a really specific way.
Not just, is this okay?
No, not that. It's more like regularly checking in on their specific willingness to participate in a proposed activity or discuss a sensitive topic. This simple act gives the shy client concrete practice in voicing their preferences.
It also transfers power. I mean, if they say no and we respect it immediately, that reinforces that their boundaries matter more than any verbal reassurance ever could.
Absolutely. And for those clients who are really hesitant to express views verbally, the article strongly suggests inviting them to use different modalities. We don't always have to rely on spoken words.
So like inviting them to write down their thoughts or maybe journal in the session or even sketch out a feeling instead of forcing a verbal response.
Exactly that. It respects their limitation while still facilitating the processing we need for clinical movement. It just lowers the barrier to entry.
And this connects to the bigger idea of formalizing feedback. The article's most actionable tip seems to be implementing structured feedback mechanisms right within the session plans.
It is.
I can see some clinicians pushing back on that, though. Wouldn't using rating scales or written feedback just feel like another kind of pressure?
That's a really thoughtful caution. I think the key is that the structure has to be independent and nonverbal.
Okay.
The source emphasizes that structured feedback, like a brief written reflection or a visual rating scale, lets them express concerns without the direct pressure of saying it to our face.
Ah, I see.
The goal isn't a perfect score. It's to give them a concrete, non-confrontational way to shape the therapy. It sends the message. Your needs actively shape this room, even if you can't say them out loud.
That reframes it completely. It's an indirect conduit for their voice.
And finally, let's just touch on self-disclosure. Clinicians are often really cautious about this, and for good reason.
For sure. I find it the riskiest area. How do we use it therapeutically here without making the session about us?
It has to be controlled and precise. The article notes that even sharing a minor relatable experience or a private anecdote that's closely related to the client's experience can break down barriers. The point isn't detail, it's validation.
It humanizes the therapist.
It does. It downscales that perceived power differential that so often intimidates shy clients. And it gives crucial validation to the quiet client that their feelings are understandable.
It's those little warm touches, as the source puts it, that go beyond the textbook and genuinely foster trust. It shows we're a person, not just a role.
It creates safety.
Mhm.
And that safety is what eventually allows the shy client to become less guarded. So if you want support tracking those subtle session-to-session changes in Alliance for your quieter clients, those vital shifts you might miss, Alliance Genie can help you reflect on those dynamics objectively and without storing any recordings.
That brings us right back to the core lesson of this deep dive, which is that rapport, especially with reserved clients, just cannot be forced. It's a slow, gradual process defined by patience and curiosity. We have to prioritize their comfort over our urge to gather information. So what steps can you take this week to proactively normalize silence in the room and communicate that their comfort matters more than how much they share?